We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I'm your host, Dr. Lauren Levine. So welcome everyone. We had a great turnout this evening, well over 900 people that are registered. A lot of you are logging in right now. I'm going to do a little bit of housekeeping for a couple of minutes, introduce our speaker, and then we'll go from there. First and foremost, I hope that everyone is staying healthy and safe. Secondly, I commend you for being here this evening, continuing your dental education. I know the last few months for a lot of us have been really topsy-turvy, but a number of the practices that I work with they're just jamming right now. They're super busy. Others are, going through some rough spells, but it will end. We will get over this at some point. So stick with it. And obviously, the need for dental education never ends. So I applaud all of you for being here this evening. I'm only going to speak, as I said, for a couple of minutes tonight. I want to make sure that Dr. Nazarian can speak for as long as he needs. We also want to make sure that we leave some time at the end for questions. Most of you have been on webinars in the past. You kind of know how the thing works. You have a control panel on your screen. You can type in your questions as you think about them. I don't normally get to the questions until the end. And typically when we have 900 plus people registered, we're not going to get to all the questions. I apologize ahead of time. I'm the only one that can see the questions. I try to combine some of them. I try to find some themes so that we get to as many as possible. But just type them in as you think about them, and we'll do our best to get to as many as we can. In the next couple of days, expect to get a few things. First off, this webinar, like all the webinars, is being recorded. So don't worry if you can't stay to the end or get distracted. You will be sent a link to download the recording. We record the whole webinar. During the webinar, Dr. Nazarian is going to be demonstrating a number of products that he uses, which are exclusive to Golden Dental. As always, I wanted to thank Golden Dental for their sponsorship of these webinars. Most of you have been on a number of these webinars in the past, and typically we have two excellent speakers, Dr. Tim Plasinski and tonight's speaker, Dr. Nazarian. And one theme that you may notice as you go through these webinars with them, you never see the same stuff twice. I went through the slides that Dr. Nazarian was showing. There's not a single case that he's shown before. So you don't get, like a lot of speakers, where you get a lot of stuff regurgitated. This is all new material. But, I thank Golden Dent for their ongoing continuation of the sponsorship of these webinars. They're committed to this whole process. The other thing, speaking of Golden Dent, always after the webinar, I get dozens of emails asking about continuing education credits. The way it works is that if you're on for the webinar, and I think you have to be on, I think AGD requires like 75 or 80%, whatever the number is. If you are on for the bulk of the webinar, you will be sent a CE certificate. There's no test to take at the end. You just have to be on for that bulk of it. With this many people that were on this evening, don't be surprised if it takes up to a week or two to get those CE forms out. They do go out always, but we have to go through it. We have to see, who was on for the right amount of time, and then they all go out. So please be patient. And with that out of the way, I wanted to welcome back Dr. Ara Nazarian. He maintains a private practice in Troy, Michigan, with an emphasis on comprehensive and restorative care. He's a diplomat in ICOI, that's the International Congress of Oral Implantologists. He's an adjunct clinical instructor at the University of Detroit Mercy School of Dentistry. If you read any published journals, you've probably seen his stuff out there. They've been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted many lectures and hands-on workshops on aesthetic materials and dental implants throughout the U.S., Europe, and Asia. He's the lead faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, immediate dentures, and all aspects of dental implants. So, Ara, it's great to have you back, and we're looking forward to tonight's presentation.
Great. Thank you, Dr. Levine. I'm honored to be here tonight. Well, tonight we'll be speaking on guided full arch dental implant reconstruction. It doesn't matter where you are, whether you're in the suburbs or the inner city, we're starting to see a lot of patients that are presenting with dentitions that are no longer restorable. And so our goal tonight is to illustrate and educate you on how to implement full mouth reconstruction. Now, obviously, you're not going to learn everything in 1 hour webinar. So we'll be talking about some seminars that we have at the Amplify Teaching Center, where we go into this in more detail. Here's an occlusal view of the reconstruction that we did. on this patient. And you can see we actually removed 32 teeth in this patient's mouth and restored them with 8/8 implants and fixed bridges. So today we find that there's an aging population that's living longer. And what we found in the studies is that age is directly related to every indicator of tooth loss. So as patients mature, they may lose some dexterity. They're not able to clean their dentition as well as they used to. They may take medications that dry their mouth. They may take medications that may create other issues. But most importantly, with age, we see that eventually patients may lose teeth. They may not lose all their teeth, but they will lose some teeth. Outside of the baby boomers, we also have a new generation of patients. These are the young patients from 20 to about 30, 35 years of age. And we find that the intake of soda drinks, the intake of energy drinks, and also we see the use of drugs such as methamphetamine is really devastating to their dentition. And so it's not uncommon for me to have one of these patients come in at least one a month, a young person around 20, 22 years of age, where their whole dentition is just shot and we have to take out all their teeth. They're just not restorable anymore. So this is another group of individuals that do need full mouth reconstruction. And then again, we have our regular patients that may have advanced periodontal disease, may have severe bruxism to the point where these teeth are becoming mobile. They may be taking medications that are causing a lot of dryness in the mouth, so they're getting a lot of root caries. So there's a lot of different reasons why we need to do full mouth reconstruction, or we need to at least take out all the teeth and stabilize their dentition. So what's your recommended treatment for these types of patients? Obviously, if we could do a two-stage process of implants, that would be ideal. A two-stage process is essentially taking out all the teeth, placing grafting material into those sockets, placing the patient in an immediate denture with a soft reline and allowing it to heal for 4 to 6 months, and then coming back for the second surgery and implementing the implants with fixed provisional restorations. But today's society does not want to wait 8 to 11 months to get fixed teeth. They've seen the advertisements of getting teeth on the same day of the extractions. So with today's marketing and today's advertising, patients really don't want to go through a two-stage type surgery. If they're going to be having these teeth removed, they definitely want to walk out with fixed teeth. So some of the available options to propose to your patients when full mouth extractions is necessary is number one, we talked about it, is dentures or immediate dentures. Another option may be small diameter implants. And in our practice, if we use small diameter implants, it's only for denture retention. They're not used in fixed cases. We can also use traditional implants in the lower arch. Usually we find that these patients are okay with an upper denture because there's some retention. There's a good seal with the palate. But with the lower denture, there's usually some looseness or mobility of that lower prosthesis. So in that regard, people would rather have some type of retention. And so if this is the only thing that fits their budget, we'll place 2 to 4 implants in the lower arch as an overdenture type of restoration. We've also used overdentures in the upper arch, opposing natural dentition or fixed restorations on implants. And in some cases, we want to avoid anatomical structures such as the maxillary sinus, then we may decide to angle our upper implants or even the lower implants if we want to avoid the mandibular nerve. And then obviously the Cadillac type of treatment is going with axially placed implants, which means straight implants. In some cases, we may need to do sinus grafting, and in some cases, we may not. But these are the options that I usually propose to my patients. and I'll give them a price range of each one of these treatments and see which one fits their budget, which one fits their needs and their lifestyle. I've been very fortunate to have restored several hundred dentitions with full mouth reconstruction. And the reason that I wanted to show this slide is to illustrate to our viewers that you can use just about every type of implant that is out there that has aggressive threads. So some of the examples of what you see can be Noble Active, or I should say that I've used in my practice. These are just some. Noble Active, MIS, Han, Megagen, BioHorizons, Oko Biomedical, and even Addon. In fact, lately I've been using the Addon, and we found that with the OsseoFix surface, which is an osteoconductive surface, we're finding a greater bone to implant contact, or at least I have personally, and we're able to go to final restorations a lot faster. So this is an example to illustrate that patients want fixed teeth, and 8 out of 10 times they will find a way to finance this. We have a lot of different financing companies, Alpheon Credit or Lending Club or Care Credit. These are all good companies to help assist these patients into getting the dentistry that they desire. So where do we start? Let's take a look at a simple example. Before we do, I want to illustrate to you 3 of the main sources of where I've learned a lot of my dental implant education. Number 1, Dr. Carl Misch. I was very fortunate to have him as a mentor and to learn implant dentistry from him. And I would say his book that is excellent is Contemporary Implant Dentistry. Georgios Romanos talks a lot about immediate loading in his book, Advanced Immediate Loading. And then lastly, Edmund Bedrosian's book that talks about all-on-4 type restorations and angling implants is also a great resource. So if you want to start doing more of these cases, I would highly recommend these 3 books. A 4th book that I also want to add on there is from Dr. Saj Jivraj, and he talks about the graftless solutions for the edentulous patient. And that's also an excellent book that I need to add onto these 3. So let's take a look at an example. In this example, we're going to see extractions, leveling, grafting, and the placement of immediate implants with a fixed temp. And that's what most of the people are listening to this webinar want to see. So this patient presented to my practice dissatisfied with her smile. In fact, she was embarrassed to smile very big. She had lost several teeth at an early age, so she was worried about not having enough bone for dental implants. In fact, when she was visiting family overseas, she had recently had some teeth extracted and was not comfortable with the way that process went. And so she decided she definitely wanted to have treatment done here in the States, and she wanted to be able to smile and eat again without any embarrassment, especially since she works with a lot of people. So when a patient presents to the practice, we have what we call the new patient protocol. And our goal is to make our patients familiar not only with the staff, not only with the practice, but also with some of the accomplishments that we've all made in the practice. And so the staff will give them a quick tour of the office. We have an area we call the Hall of Fame, which illustrates some of the articles that I've been fortunate to have published. We'll also show them the sterilization area. It's important that patients see how you're sterilizing your instruments. We ask if they need anything and return them to the lobby. And then at that point, we have them fill out the paperwork. And so immediately the patient already feels like they're at home, or that we're different from most practices just because we didn't have them fill out paperwork right from the beginning, and we try to get familiar with them and make them familiar with our practice. Once they filled out the paperwork and the questionnaires, while they're waiting for that paperwork to be processed into the computers as a new patient, we'll give them a before and after book to look at of the various procedures that we've been able to do as a team. And so our goal is to educate these people step by step. So once they've been seated into the operatory, we'll go ahead and do our clinical exam along with the necessary radiographs. In addition to these, we'll also take extraoral photos as well as intraoral photos. If they need models, we'll take models, whether they're analog models where we're pouring up impressions or where we're using a digital or intraoral scanner. And then lastly, most of these patients are coming in for implant therapy. So we're not only going to get a 2D X-ray, but most importantly, we're going to get a CBCT. So this is the usual set of photos that my assistants will get that are automatically put up onto the monitor so that when I enter into the room to introduce myself, these photos are up. It's important to note when these photos do go up, before I enter the room, the patient will usually look at the staff and say, are those my teeth? They've really never seen some of these views. And so sometimes when teeth are really decayed or severely infected, they actually see how bad their problem is. So the saying goes, a picture is worth 1,000 words. Well, it's totally true. And so when I enter the room, these are already up and the patient has already visualized what's going on and knows that we're going to address these needs. So once I do my intraoral examination, our goal is to identify any caries or crazed lines and cracks, broken teeth or restorations. Do they have some type of prosthesis? How's the fit of it? If they are edentulous or partially edentulous. We'll also check their gums. Are they bleeding? Do they have periodontal disease? Are their teeth very mobile, or do they have severe areas of wear or bruxism? So when we look closely, we can see some of the things that are going on. We can see that she has somewhat of a crossbite on her right side. We can see some areas where the teeth have hyper-erupted. We can see some wear in addition to that. So there are several things we're looking at when we look at these patients. When we look at the occlusal aspect, the area looks healed from where she had recent extractions. But upon visualization of her CBCT, as you'll see in just a moment, we'll see that some of these areas may not be the most ideal for the placement of dental implants. In the lower arch, we see that her gums may not be the most ideal, that she has some occlusal wear. She had some deep probings. However, the lower teeth were not as bad as the upper teeth. So what we recommended in the lower arch was scaling and root planing. So our first thing is obviously to acquire the CBCT. The CareStream 8100 is the CBCT in my practice. It works very well for the type of dentistry that I do, and the field of view is perfect for what I need. And I do full mouth reconstruction. So the 9x8 field of view is more than enough. The unit is very effective, yet efficient. We can go as small as a 4x4. We can go as large as a 9x8. And we can really identify different things, not only on the 2D, where there's several filters that you can clean up, but they also have software in their CBCT to remove any type of scatter that may be caused from metal restorations or zirconia restorations. Now let's quickly take a look. If we look at the top left field, that's called the axial view. And if you look at the regions of number 4, 5, and 6, 4 and 6, most importantly, we see there really isn't a buccal plate that's remaining in that area. So that may not be the most ideal area of bone to place dental implants. We also see in the area of number 11, 12, and possibly 13 that there definitely was no grafting placed at the time that those teeth were extracted overseas. When we look at the lower right view, which is the cross-sectional view, we see that in the area of tooth number 9, there really isn't a lot of width for a dental implant. In fact, you can see the incisive foramen. And so when we place implants, our goal is to have at least 1 to 1.5 millimeters of bone on either side of that implant. However, sometimes that just may not be the case. So this is a challenging case when we look at the CBCT as compared to the clinical views. So it's imperative if you're going to be placing dental implants, you need to get a CBCT within your practice. So looking at the close-up views of each of the 4 squares, here we see the 2D view or the Panorex view. Here we see the cross-sectional view, and notice there isn't a lot of bone. Here we have the 3D view, and you can see the areas where the teeth were recently extracted. The bone composition is not the most ideal. And then lastly, we see the axial view, where in fact the buccal plate is either A, broken, or B, just very thin that it's not even showing up on the radiograph. So when you look at this, I want you to visualize, if you're going to be doing an all-on-4, where exactly are you going to place these implants? This is not the most ideal case to start with. Well, we're still going to go over the different types of options, and you remember this from the different panoramic views, starting from dentures all the way down to fixed bridges that we illustrated previously. But I just want to spell it out for you so that you can see. So in the treatment of the maxilla, the following options were reviewed with the patient. Number 1, a removable denture. Number 2, some type of overdenture. And then lastly, some type of fixed bridge, whether it's all-on-4, all-on-6, or parallel implants. Now, in this patient's case, if we were to do parallel implants, then obviously we would probably have to do it as a 2-stage and do sinus grafts. So her goal was to probably focus on something fixed, or she wanted something fixed, I should say. So we focused on either an all-on-4 or all-on-6 type restoration. Now, the quality of bone was not the most ideal, so I decided it's probably better to place more implants than less. So we probably go with an all-on-6. That way, if in one of those areas where the bone was thin, an implant failed, it wouldn't be catastrophic. We could still do some type of restoration on the remaining 5 implants. So we chose to go with all-on-6. So this is what our goal is. When we do an all-on-4 or all-on-6, usually our restoration is going from 3 to 14. We're not trying to place a second molar. So they're usually getting a fixed bridge from number 3 to 14. In some cases, number 3 and 14 may be a cantilever off the fixed bridge, depending on the anterior posterior spread that we're able to achieve with this case, or with the case that we're working on. So using the CareStream software that comes with the 8100, which is, by the way, a very easy software to use, I can plug in any type of implant and start to plan exactly where my ideal position is to place an implant. So here you can visualize where our goal is to go with 6 implants, not 4. So you can see that in the 3D view. Now, this is something that I acquired from Dr. Saj Jivraj's book. Dr. Edmund Bedrosian also has this in his book, and it talks about the different zones of bone. If you're going to be placing full mouth reconstruction or placing implants for full mouth reconstruction in the upper arch, it's ideal that you visualize the different zones of bone. So if a patient has bone, ideal bone, in zones 1, 2, or 3, then we can place parallel implants like you saw in the very first case where we had 8 implants in the upper arch. If the patient only has bone in zone 1 and 2, then we're limited at placing all-on-6 or all-on-4. Now, if they only have bone in zone 1, then we may combine 2 traditional implants in zone 1 in addition to zygomatic implants. And if they have insufficient bone, which means they don't have enough bone in any of the zones, then we would refer them out for quad zygoma. So I would say 8 out of 10 cases in my practice, I'm doing some type of tilted implants in the maxillary or mandibular arch. If it's a patient that needs zygomatic implants, then I am currently referring that out to the specialist. So with tilted implants, some of the advantages are the following. Only 4 to 6 implants are required for full arch reconstruction. Again, my preference is to go with more than less if I can. So my goal is to always try to go with 6. If I can't, then I'll go to 5 and then to 4. We try to avoid implants in the posterior region so that we don't have to do sinus grafts. Usually we're only going up to about 30 degrees in the tilting of the most posterior implants. We're using a cantilever, but only a molar cantilever, so only one tooth, and that's usually 3 or 14 if necessary. Otherwise, our goal is to not have any type of cantilever. We always want to try and get these patients to leave with immediate functional temporary, so a fixed temporary. I found that the add-in implants, as well as some of the other ones that we mentioned, work very well because we're looking for aggressively threaded implants. Very rarely am I able to do this flapless because most of the patients that present to my practice do need some type of extractions and leveling. I'm not that fortunate to get patients that um, present to my practice already edentulous where I could do a flapless technique. And then obviously we're going to do bone reduction. We want to try to eliminate any type of transition line that's visible. So when we look at our planning, you can actually see how very limited this case was. And although those implants look like they're very large on the screen, those are in fact 3.25 or 3.3 with implants. So you can see it's very tight. In these particular cases, we under-drilled, we expanded with osteotomes, and then we placed the implants. So before we start doing this case, um, surgically, we want to do what we call a records appointment. And this records appointment, we're able to identify the incisal edge, the lip line, the transition line. We're going to achieve upper and lower molds if we're using traditional impression materials. The Silginat from Kettenbach works very well as their Futar Fast, which most of you may recognize from that mint green color. Or you can acquire the impressions digitally. We also have the CS 3600 from Carestring that works well in that regard. When we're looking at talking to the laboratory about immediate dentures, our goal is to not just say, okay, make an immediate denture shade B1. Our goal is to go ahead and illustrate to them where the horizontal plane is. Where's the anterior tooth display in the upper and lower arches? Is the midline on or is it off? And does it have to be moved to the patient's right or left? Or do we keep the incisal edge the same and use that tooth as a guide for the immediate denture? And so these writings are an example of what I will forward to the laboratory in addition to the photos, so that the laboratory is not guessing when we're trying to create an ideal temporary or an ideal immediate denture that's going to be converted that day. Here you can see we used Arrowhead Dental Lab, and so I'm going to identify that we need immediate dentures, that we're going to extract all the teeth in the upper ridge and level about 2 millimeters. And so our centrals we want to be about 9 millimeters in width, and we want to follow some type of golden proportion so that the teeth are symmetrical. Now, once I've acquired all this information and I've planned in my Carestream software, I will forward this information to 3D Diagnostics, and one of their doctors on staff, as well as the technicians, will convert it to the software that they use, which is Co-Diagnostics. And so here you can see the 3D image that they've assembled, and you can quickly visualize that the bone is not the most ideal in some of the regions. However, like I said, our goal is to place 6 implants. And if one were to fail, at least we have 5 more, or if 2 were to fail, if they're not the most distal implants, then we can use the other implants as a safeguard. So this is the type of 3D imaging that you'll get from 3DDX in the planning stages. And here again, you can see where the bone was very deficient, not dense enough to even show up on the CBCT very well, or in fact, there's quite a bit of a void here. So again, this is not a case to take on as your first all-on-4 or all-on-6. But this is just an example to show you what we did guided with the assistance of 3DDX. So day of surgery, we're going to go ahead and anesthetize the patient. Here we are. And so our goal is to take these teeth out atraumatically. So this is an instrument that I created for Golden Dent. It's called the wedge. It doesn't work like an elevator. It's more of like a luxator and a periotome. And so it works very well in loosening the teeth so that we may take them out with the physics forceps. You can see as soon as I put just a little pressure there to luxate the teeth, we saw that the splinted crown restorations immediately popped off, which is fine, not a problem. I rather have those separate. So I loosen the teeth and allow the hyaluronidase enzyme to be released. While that's being released, I'm going ahead and reflecting a flap. This is another instrument that I created called the reflector. And this allows you to reflect a flap very efficiently and effectively so that you can place your bone level guide onto the region. Once we've reflected the flap, I go ahead and now that the teeth have loosened up on their own, I'll go ahead and utilize the physics forceps to further loosen the teeth so that I may atraumatically extract them. So the physics forceps is from Golden Dent. Our ideal tooth extraction is literally the painless removal of a whole tooth or root with minimal trauma to the investing tissues. So really, our goal is to take a tooth out atraumatically so that we preserve the surrounding tissues, most importantly, the bone. And essentially, the physics forceps works like a modified class 1 lever. So you don't really have to put too much force when removing them. When you look at this example, what makes more sense? In this example, what makes more sense? Obviously, using the hammer as some type of lever makes more sense than the pliers. So Archimedes has been quoted as saying, "Give me a place to stand and a lever long enough and I will move the world." Well, our goal is not to move the world, but to at least take teeth out atraumatically so that we can place implants. Because as you saw in this particular case, I'm very limited with the amount of bone that's remaining when the patient even presented to the practice. So when implementing the physics forceps, our goal is to place the beak on solid tooth structure on the palatal side or lingual side, and then place the bumper as high up into the vestibular area as possible. Do not squeeze. Our goal is to leverage the tooth so that we get movement. And as soon as we get some movement, we'll go ahead and use a forceps or even a tooth delivery forceps to remove it. So if you take a look at the buccal plate, even with the buccal plates being very thin, utilizing the wedge as well as the physics forceps from Golden Dent, we kept everything intact. And so here we'll further reflect the flap so that we may seat the surgical guide. Now, if you take a look, you can actually see some of the voids in the areas of where her teeth were extracted. You can see there's a large void in the number 4-5 area here. We can also see the little void in the 12-13 area. And we can see the molar areas may not be the most ideal to place an implant and achieve primary stability. Here we have the surgical guide from 3DDX. So what we'll do is with incremental sizes of sleeves, do the drilling and place our implants. So we want to ensure that this surgical guide is seated completely without any movement onto the level of bone. If you find that it's lopsided or it's tilted or it's not seating properly or it's rocking, that usually means you probably have not removed the gum tissue apical enough or you have not reflected a flap far enough. And so here we can see we're placing the implants after we've done our osteotomes. You can also see the further grafting that we've put. You can see the stachy bone here and some of the other bone that we've done where we've taken cortical and cancellous bone and we've mixed that with their blood. Here we can see our suturing. This is her immediate denture that the laboratory fabricated for us. So we're going to convert the positions of the multi-unit abutments using the bite registration from Kettenbach. This is the Futar bite. And then we'll go ahead and open up these holes. And here we're using the Tokiyama Rebase 2, which is a very good material, solid. The only thing you have to do is mix this so it's not self-mixing. Load it into a monojet. And then here you can see the temporary cylinders that were picked up. This is 1 week post-operative. And here's the x-ray that we took. You can see the 6 implants that are placed. So you can see her smile is good. We decided that we want less gingiva showing. In this case, she's not smiling as big, and we wanted to thin out the upper lip a little bit. So this is what it looks like as it's healed 4 months later. You can see a little bit of the titanium temporary cylinders, not a problem. And so here's her before and after pan 4 months later. And so now she's ready for impressions. This was an open tray impression using the using the impression material from Kettenbach, which is the Panasil. Here we have the final zirconia restoration. And here is her final view 4 months later. Here's a close-up. You can see how nice the gingival tissue looks. Our goal is to have a convex surface underneath so that this patient can cleanse it very well. And notice now when she's smiling big, the transition line is still hidden, so you can't see the seam of where the fixed restoration and the tissue meets. So it's not visible. All right, so let's take you to another example. And this one is upper and lower. This patient presented to the practice dissatisfied with his teeth. They were causing quite a bit of pain. You can see he's got somewhat of a gummy smile, so we know that we immediately will have to level bone to hide the transition line. And so these are the things that we're going to go in great detail October 9th and 10th here in Michigan at our full mouth guided implant course in Michigan. So I just wanted to give you a little taste of that and see what we go into in detail. So these are some of the views that we acquire. Notice in the lower arch, the patient also has mandibular tori that are pretty good size. So number one, we're going to evaluate where's the transition line going to be. We know we have to bring that up apically so that it's not visible. Number two, we want to identify where the midline is. The last thing you want to do is a $50,000 or $60,000 case and your midline's off. So we want to identify to the laboratory for the temporaries and provisional restorations, and then obviously to the final restoration. So this is an automatic sort of checklist that we do when I'm doing the consultation. The other thing that we can see is that he has a very deep bite, or these teeth have hyper-erupted, but you can clearly identify that we need to do some leveling or we need to open up this bite because there's clearly not enough room if we were to just do single implants in a couple regions. And obviously you can see he's got rampant decay. So we go over all the different options with this patient. And he chose to go with fixed, obviously, fixed over fixed. Here we can see the large mandibular tori. The patient complained that it was hard to brush his teeth because his teeth were so sensitive and painful. So you can see the plaque buildup on some of those teeth. We look at the right and left lateral views, and you can clearly see if your goal is to place single unit implants and try to do crown and bridge with root canals, it may be a pretty challenging case. And especially with his high caries rate, I would not personally suggest it. Here again, we're using the 8100 CBCT to acquire his 2D and 3D image. So here we can see the 2D image, and you can see the large sinus cavities on both sides. And then when we look at the CBCT, we can also see that in the axial view, but then also in the cross-sectional view, we see we don't have the most ideal bone. Using the software with the 8100 3D from Carestream Dental, I went ahead and planned for some implants. So in the upper arch, you can see that I have 1, 2, 3, 4, 5, 6. And in the lower arch, we have 1, 2, 3, 4, 5, 6, 7. So sometimes it may be an odd number. Like I said, I may place 5 in this particular case. I may go with 1 extra. And so we went with 6/7. And so we'll forward that to 3DDX so they can convert that into their co-diagnostic software. One of the doctors there will review it with us and do a WebRx meeting. And here you can see where they're recommending that I level the bone so that we have an ideal platform for the prosthetic portion of this restoration. Again, we decided to use the Panasil impression material, and this was actually for the preliminary. Usually we'll go with the Silginat, but in this particular case, I want a little bit of a putty to spread the soft tissue out of the way. So this is from 3DDX. You saw we converted a denture in the earlier case. Now, with the technology that the labs have, we can actually have pre-milled PMMA temporaries with the holes already in them. So let me take you through this scenario. This is what they call the bone foundation or leveling guide. This is the surgical guide that you will snap onto that once you've leveled the enough bone. So it goes something like this. This is the abutment orientation guide so that you know how the internal aspect of the implant should be so that the multi-unit abutments are in the proper orientation and angles. And here we have the PMMA temporary restoration. In the lower arch, again, we have the same thing. This is the foundation guide. This is the surgical guide that snaps on once we have done enough reduction. The abutment orientation guide, and then we have the PMMA provisional. So this is what it looks like. Now, as backup, we always will have immediate dentures. And the reason that we have immediate dentures as backup with these full guided cases is in some cases, you just may find that you don't get fixation of, let's say, the most 2 distal implants or something. And then so if we can't achieve about 30 to 35 Newton centimeters for each implant, usually I try to go 35 to 60 is my ideal range. We'll go ahead and soft reline and we'll place the implants, but we won't load them. So we have all the necessary materials from our guides to our implants to the provisionals, as well as the backup immediate dentures. We anesthetize the patient and we atraumatically extract all the teeth. We're go ahead and reflect a flap. And in some cases, you just may have a buccal plate that fractures a little bit. We're not too concerned because we're going to be leveling this bone as you saw with the transition line. Usually the areas that will have a little bit of a fracture on the buccal plate are usually the canines. Sometimes we'll see a first premolar. Our goal is to now place the bone foundation guide with the fixation pins, and then we'll go ahead and level the bone. This is from Golden Dent. This is the osseous cleaning and shaping kit, and it's got all the necessary burrs to clean the socket or to level the bone. And so here you can see where we're leveling the bone using our surgical handpiece, so we have sterile water irrigating that. At that point, we'll go ahead and place the surgical guide. Notice you have the 2 plastic inserts that confirm that this guide is positioned onto the foundation guide. And so we'll go ahead and place the implants through the guide. We'll further seat them. That was not a fully guided kit, so that's why it wasn't seated through the guide. We'll go ahead and place the abutments, confirm that we have them positioned and oriented ideally, place the temporary cylinders, and then at that point, go ahead and use the gasket that's enclosed from 3DDX so that we don't get hard reline material into the sockets. So you can see now you can fill this with the hard acrylic. Usually what I like to do is take impression material, like a light impression material, and put those into the temporary cylinders so that acrylic doesn't go in there. Or you can use these little sticks. These are just the cotton tip applicators. I find that the impression material works better, so I've been using that more recently. So we're going to go ahead and use the Tokiyama rebase. We're going to mix it and place it in the syringe as we indicated earlier. And so here we pick this up, and now we can go ahead and add further material so that it's flush with the provisional restoration. And then we'll go ahead in the back and polish that up. Notice we don't have a cantilever on the provisional restorations. When doing these immediate fixed restorations, we really don't want cantilevers. When it comes time and these implants have osseointegrated, then we can place the first molars on. So now that we've created the provisional restoration and we're waiting for that to set, we're going to go ahead and cover these with the temporary cylinders so that we don't get any bone product into the multi-units. So here's the addition of the grafting material from Golden Dent. This is a blend of corticocancellous, mineralized and demineralized. And so now that we've sutured that, we're ready to work on the bottom. Again, as we indicated in the upper arch, we're utilizing the physics forceps to atraumatically extract the teeth. And so on the lingual aspect, those two bean-shaped anatomies are actually the tori. So we actually have to reflect the flap past the tori. And so you're going to see the most precise fit here in a second of this bone foundation or leveling guide from 3DDX. And so you can see it went over the tori and seats right there. It's fixated with our retention pins. And so at this point, we'll take the bone leveling burr from the Golden Dent kit and level the bone. At this point, we'll place the surgical guide. This is a precision fit that goes right on top of the bone foundation guide. So if you have not leveled enough, this will not seat. We'll place our implants and then confirm that our multi-units are placed at the proper orientation. Once we've acquired that, we'll go ahead and place our temporary cylinders, position the gasket and the PMMA temporary. You can see it's totally sealed, and then pick that up. Take it in the back lab and add to any areas of voids. Place the little plastic caps for the multi-units, and then place grafting material. We don't like to place the grafting material until we've put these white caps on. Otherwise, you're going to get bone particles within the multi-unit abutments. So that would not be very good. So notice we place the white caps and then place our grafting. Now, my goal is to remove the foundation guide. And I said, there's no way that I can leave these sharp areas of tori. So I decided to remove them. So I took a 169 long and removed that, and then just use a chisel and popped the tori off. So this is what it looks like as I'm just redefining the provisional restoration. I'm picking up the provisional restorations myself. I don't have a lab technician in the office. And so this is what it looks like. And so this is what it looks like as the patient left. This is 1 week later. And so here we can see the 6/7 implants placed as ideally as possible. The nice thing about this surgery, it was all under 4 hours, start to finish, including the prosthetics. So it definitely makes us more effective and efficient when we're using CBCT guided surgery. Here we have the fixed provisionals about 4 months later. And so here we're going to take pictures and criticize and say, look, we need to remove more gum and make these teeth a little larger. If you remember, his previous teeth were larger. And the patient understood that this was just a provisional restoration. So using this information, we're going to give the laboratory feedback We're going to let them know about the thickness and what we can do. And so we'll go ahead and acquire the impressions. These are the open tray impressions using the Panacil from Kettenbach with their bite registration. The laboratory will send us back a wax try-in, so we'll try this in to see if the positioning of everything looks good. We'll get the patient to sign off on this so that the laboratory can go ahead and fabricate the zirconia restorations. My preference is monolithic zirconia with the pink porcelain on just the facial aspect. And I found that works much better than layering the teeth. I don't want them to fracture. So here you can see the technicians have done a really nice job to make it look like the incisal edge is translucent. Here we've placed the fixed final restorations. Close up of both upper and lower. So here's a before and after. You see the midlines corrected. Nice occlusal table. And here you can see that the profile of this prosthesis is not very large or wide. So this is going to function more like a natural or like a bridge on natural teeth instead of a very thick type of hybrid. The beauty of this is because we did it at the same time of the extraction, so the patient didn't have a lot of resorption, because as the maxilla resorbs, it goes more palatally. And here you can see we've already placed the Teflon, and then we'll use composite to plug the holes. Here in the lower arch, notice that the tori were removed, so now his tongue definitely has a lot more room. And so here we can see the before and after of both maxillary and mandibular arches. Here we have the Panorex view. And here we have the full view of retracted as well as the radiographic views. Okay, I think I finished just on time, Dr. Levine.
Thank you very much. That was great information. We had a number of questions coming in, but I wanted to turn things over briefly to Kurt Lawler. As I mentioned, we are very fortunate to have sponsorship from Golden Dent. Kurt is always kind enough to offer some very special pricing for some of the things that you saw during tonight's webinar, as well as to go over some of the training options that are available. So I'm going to turn the screen over to Kurt, and I think his mic is live as well. And there we go. Take it away, Kurt.
All right, appreciate it. Hello, everybody. My name is Kurt Lawler. I'm with Golden Dent here in Detroit, Michigan. For those of you that are maybe unfamiliar with what we do or with our company, we're, like I said, a Detroit-based company. We operate under the principles of providing simple, predictable, and unconventional dental products. So we always try to find unique dental products that work a little unconventionally than how things are normally done. And so we're a third generational dental family here in Detroit. And we're in the third generation now being in here in the dental business and not practicing dentistry. So I'll mention this quickly before I get into a couple things. We, as Lauren mentioned, we do offer a promotional code just as a thank you for investing your time with us this evening. Maybe you saw a specific burr kit or an instrument that was interesting this evening throughout the presentation. We do these deals for a quick 24-hour special, and the code for this evening is going to be Plan 12. So it's just PLAN 12, and that will we have, I guess, a matching percentage with the Plan 12, which would be 12% off any of our products or our educational courses that I'll discuss here in a second. So it's Golden Dash Dent. There's a dent in there, or sorry, a dash in the website. Sometimes that's confusing, so just be aware of that. And then obviously you can connect with us through the phone or chat feature, or give us a call in the office. So Amplify is our training aspect of what we do. That's our educational aspect of our the product-based company, which is Golden Dent. So Amplify Dental Training, we have some really great live patient hands-on programs. I guess we say, we were the most hands-on live patient dental in America, and I kind of added theirs, before COVID. So we used to do these programs on a regular basis where we had 125 to 150 plus people involved with the staff, the patients, and the doctors attending, and it's a really great program. But those are currently put on pause, I guess, for the rest of 2020 here, like a lot of things, while we figure out, what makes the most sense in the realm of the COVID-19 realm. So right now we're focusing more on the classroom-based courses, which are obviously going to be safer for the participants and probably going to be the better solution, I guess, maybe for the rest of this year. So we have a great program coming up here. This is actually a picture of our facility in Detroit. It's actually in Roseville, Michigan, a suburb of Detroit. It's October 9th through 10th, and we're going to discuss this exact topic. It's a guided full arch reconstruction with Dr. Nazarian, where we have some really great hands-on modeling work and obviously much more comprehensive step-by-step instruction on what was discussed this evening. It's obviously hard to fully learn this topic, obviously, in a 45, 50-minute webinar, and we'll go through this in great detail at our program. If you're interested in that, we're more than happy to give you information on that. I think we're going to try to limit it to no more than probably somewhere around the 10 doctor range, just to properly space everybody and just be safe, like I said, with the COVID restrictions we're facing. So with the product base, with the products at our company, Physics Forceps, that's what started our company back, I think about 13 years ago now. And this was our first product. Still a great product. This is our standard series instruments. If you're going to do these full mouth cases, you obviously have to be comfortable with extracting teeth. This is a great way to do it. If you're already extracting teeth or maybe damaging bone or struggling with it or referring more than you'd like, this is a good opportunity to try something new. If you're not familiar with the product, you have 30 days to try it out, see if it's the right fit for you. And this would definitely be the one I would recommend. It's called our standard series. This is going to work second molar to second molar on the upper and lower. We have another series, which is these two here. These are more for erupted third molars and hard to reach second molars. But if you've never used the instruments, I think the green bumper ones here, which is the standard series, the technique and the ease of use is much easier, where you're just pushing either up or down with the instruments, where this one, they go further back into the mouth, but it's a little bit more of a slight learning curve with this set, where you have to do like a wrist rotation, like turning a round doorknob without squeezing. So we always recommend to start with the ones with the green bumpers. Make sure you're comfortable with the instruments and you like them. And then if you want to reach further back into the mouth or having issues maybe accessing second molar sometimes, this is a nice addition to the standard series set. These are conventional forceps. These are your 150, 151 ash. We made these for some of our customers that were looking for more of the conventional instruments. If you're just looking to upgrade some of the extraction forceps you have, these are really nice looking instruments. They're like a gunmetal type finish, have a really nice grip and feel to them. And again, these are just more the conventional instruments, but I just wanted to mention we do have these available too. This is the wedge. This is the instrument that Dr. Nazarian likes to use prior to the physics forceps. He already explained this in good detail this evening, so I won't really mention this too much further, but we do have this available on our website. It's not an expensive instrument. I think it's a little less than $100 with a discount. This is the burr kit. So this has pretty much everything you need to do the types of cases that were shown this evening. We have our degranulation burrs, our bone shaping burrs, a really good cutting burr for sectioning, and then just another shaping burr for shaping the bone. It looks like it's about $173 with the promo code, and that's what Dr. Nazarian helped us design, and that's on our website if you have any interest in that product. This is a straight nose cone. This is an inexpensive one. We have that available because you do need this to use the two burrs that are shown all the way on the right hand side of this kit. The bone level. I'm sorry. The two all the way to the right. The bone shaping burrs, you do have to use a straight nose cone, which we do. If you don't have one, we do have some inexpensive straight nose cones on our website. This is the reflector instrument. Again, this was for reflection of larger amounts of tissue. Again, another instrument that Dr. Nazarian had us make for him. It's a really great instrument. Like I said, just reflects some soft tissue when you're doing these more larger full mouth type cases. Graft kit. Obviously, we have plenty of graft kits on our website. We have more advanced scissors and instruments, hemostats and different instruments. If you're looking to have a really nice complete graft kit that is together, looks nice, it's ready for your graft cases. This is not an expensive kit. You can take a look at that on our website. We do have these available. You know, I'll mention this quickly. This is not going to be probably for your like full arch type cases like we discussed this evening, but this is still a really popular product for us. If you're not doing grafting now, or if you have maybe a single type case, I know Dr. Nazarian really loves this product. We talk about it a lot in our courses. This is a great alternative to your conventional type graft. I would definitely recommend taking a look at this product. You just simply place the graft material in the socket site and go ahead and cross suture it. You don't need any type of membrane, and it really does provide great clinical results. It's a synthetic bone graft and a bovine collagen type carrier. So it's a really great way to get involved with grafting if you're not already doing that, or even if you are grafting now. It's just a really economical way to graft, and it provides a great clinical results. So our bone graft, this is an allograft. Obviously, lots of companies have allograft. Ours is a very good allograft. We think it's fairly priced. If you're using a competitor's brand or another brand, we encourage you to take a look at our Goldos allograft that we teach in our programs and that Dr. Nazarian uses in his practice. Sutures. So we have a PGA suture and a black silk suture. These are the two that we teach in our programs. I think if you look at our pricing for our PGA sutures, they're quite inexpensive. And then the black silk suture is obviously very good also. I'll just kind of skipping forward here because I know we're running out of time. I'm going to mention this just quickly. It's totally off subject, but it's super hot right now with the COVID, and one of our largest selling products lately is these HVE suction mirrors. If you haven't already got a bunch of emails from us on this product, I apologize, but I just want to mention it one more time. It's been a really great and popular product. The feedback's been really encouraging for reducing aerosols. It does hook up to the high vac, and it's a mirror, so I know it's been really popular with hygienists and then different offices. So I just wanted to mention this before I stop talking here. And then lastly, this is a very simple way to minimize aerosols. This is an arm that we sourced and found that it actually works really well. It just holds the high vac with a funnel and a tube near the patient's mouth. If anybody's still looking for these types of solutions, I just want to mention we do have them available. And that's it. I'll leave this up and turn it back to Lauren and Dr. Nazarian for the questions, and I appreciate your time this evening.
Great. Well, thank you. Ara, you got time for some questions here?
Absolutely.
Some of them did come in before we started the webinar, where people were encouraged to ask their questions. So a couple of them may be a little redundant. I know you went through them, but we're going to, like I said, we're going to try to get to as many as possible. Just a reminder to what I said at the beginning of the webinar, if you were on for the entire webinar, you will be sent a CE certificate. There were some people that didn't log in until half past, 35 minutes after. Unfortunately, AGD rules would prevent you from getting CE credit for that. But for everyone else, don't worry about it. There's no test at the end. You will just be sent the CE certificate. But give it a couple of weeks, because there were, as I said, close to 900 people registered. So this is kind of a two-part question. What length was used for the posterior area for the molars for the implant? And it's a side question as to the length of the implant for the posterior. I saw a YouTube video where a doctor had used a mini implant length of 13 millimeters for the number 30 area. Is this close to the mandibular nerve? Could it be an issue?
So the first question is the implants in the upper region that were tilted were 14 millimeters. And this is a two-piece implant, a 3 0.3 is not considered a mini implant, still a traditional implant. I would not recommend a mini implant for this type of restoration.
For upper and lower, or just for uppers?
For upper or lower, I would rather you go with a traditional size implant. If you could put a 3, you could probably put a 3.3.
Okay, let's go on to the next question
And
here.
it's a 2-piece, right? A 2-piece, let's say you have to load it. If it's a 1-piece mini implant, and you don't get good fixation, how do you load that? And also on a mini implant, you can't put an angled abutment. So a 2-piece implant is much better, I think, than a 1-piece implant for this type of case when you're angling implants.
Okay. Okay, this is a question that came in before the webinar. What slows me down the most in an upper case is thinning the tissue to get a 3 millimeter thickness, which can be a challenge on the palate. Bleeding's often a problem there as well. Tricks for that?
Yeah, so there's a great tissue punch from, I believe it's Salvin, that has so that when you're readapting the palatal tissue, instead of trimming it all and removing it, you actually, it looks like a hole punch. You do a hole punch and you're able to adapt the gingival tissue much better to the ridge, and you don't have that deep tissue then.
Mm-hmm. Okay. I think this is more of a comment here. I guess on one of the cases you're saying getting the convex integual contour is easier said than done. Do you run into those issues as well?
Well, if you're not leveling, that is true. If you're leveling, if you notice, we're using almost a pear shape or a round shaped burr. So we try to create some type of concavity so that the restoration has a little bit more convexity to it, so it'll fit in there. But I would agree, it's not always the easiest to do. If you noticed in the last case, where the in the lower ridge, you could see there was an area where it went up and down, just because that area, you know, even though we shaped it, the way it healed in a funny way. So I agree. It's always a challenge to maintain some type of a balance when it comes to that ridge, but we want to try to create some type of convex surface.
Sure. In the tori case you showed, why not remove the tori and use that in the bone graft and not AD? I think you and I, when I saw the cases before the lecture started, I said, why not just put the implants in there? Those things are huge.
Yeah.
But why not use that bone and harvest it?
Yeah, you could definitely use that bone, but because the foundation guide was splinted to that at the beginning, and I was going through the various steps, I just chose to, use an allograft. Again, if somebody's trying to save on a cost, that case was somewhere between $50,000 and $60,000. Having a couple jars of allograft is not a big deal. Obviously, having an autograft is more ideal, but I was happy that I was able to remove them
Yeah.
the way that I did. Let's put it that
Okay.
way.
Well, it was a good weight loss program for them too, I'm sure.
Yeah.
Are
He's
your
walking
patients?
straighter now.
Yeah, exactly. Are your patients sedated during the procedures?
Yes.
Conscious sedation, IV sedation, what do you typically recommend?
IV sedation, like moderate sedation.
Okay. I guess you had mentioned about not necessarily using the second molars. What's the rationale for not including second molars?
Well, if I had enough bone, I'd be more than happy to include second molars. The problem that arises is that you may not have enough anterior posterior spread of the implants. So that's why we're not including them in there. And if you promise someone second molars and you're unable to deliver, they're going to remember that and demand some money back. So if you promise them first molar to first molar and you always deliver, then it doesn't create a problem. But if
Okay.
you have enough bone, then yeah, second molar to second molar, why not?
Okay. What's your preferred software for implant placement?
The CareStream software, which comes with my CBCT, it's included in there. I've had a chance in the past, before I had CBCT, to use Implant. That's not that easy to get anymore. Co-diagnostic software from 3DDX is good if you don't have your own CBCT, and let's say you get your scan at a scanning center and you want to have it on some type of software, then the co-diagnostics is good.
Okay.
Yeah.
Okay. For the cantilever, do you have a maximum measurement that you'd be comfortable with? And related to that, a minimum thickness for the zirconia?
Right. So the minimum thickness of the zirconia is usually about 14. In some cases, I have gone thinner, but we're using a metal substructure and the zirconia onlay on top of that, or a PMMA structure on top of the metal framework to go thinner. There have been cases, if it's very thin, that we've just gone with PFM restoration. But ideally, we want to be within 14 to 15 millimeters in height, as far as the thickness goes height-wise. The cantilever is just going to be one tooth, so I would imagine a molar is what, 5 millimeters mesial
Yeah.
distally.
Yeah, give or take. Okay. For central incisor implants, are they typically different as far as the diameter compared to posterior implants?
Yeah, it depends on the structure of the root. It depends on how much bone is there. Usually I'm finding, doing these cases, a 4.2 diameter implant is like the most ideal. And we've gone as short as 10 in the anterior, but usually in the posterior, we try to go 13 or 14, depending on the implant system.
Mm-hmm. Okay. With all the different bone grafting materials out there, do you have a preference? Like, if you had to use just one bone graft around an implant, what would be the one that you would mostly recommend?
My preference is still an allograft and going with a mineralized, demineralized cortical cancellous mix. And the reason for that is they resorb and turn over at different rates. So as the cancellous bone is turning over, into the patient's own bone, the cortical portion of it is acting as a scaffold. And so because those two are changing over at different times, you still have that scaffold of bone that's maintaining the height and width of the graft somewhat. And for that reason, that's my preference.
Okay. Do they have Meharry shades for the porcelain gingiva?
I'm sorry, can you repeat that? Do they have what?
Yeah, I'm not sure. It says Meharry, Meharry.
Oh yeah, they do. So yes, they have, depending on what laboratory you're using, there are different shade guides for the gingival tissue. So they have the really dark ones or lighter ones, depending on your patient population.
Okay. I don't want to get you accused of price fixing here. If someone were to have both of those cases done in the upper Midwest area, what would they typically expect the patient to pay for something like that?
So all inclusive with the sedation, taking teeth out, leveling bone, placing 4 to 6 implants, fixed provisional, and final zirconia restoration, you're looking at about 25 grand an arch.
Okay, yeah, that's what I thought would be in that range. For the surgical stents, is there a chrome option?
There are different chrome options that are out there. I'm not familiar with 3DDX providing that. I have used a lab in Florida, Advanced Implant Dental Lab, who has used some type of a metal guide, which works very well. And I know that there are some others that are out there that do use like a chrome guide, or I think it's called Chrome Guide. Yeah. So there are several guided companies out there that doctors can inquire information from, look on YouTube and follow some of the videos and things like that. Let's put it this way, Dr. Levine, guided implant therapy takes the guessing out of the placement of the implants, um, showing the patient visually and virtually where I plan on placing the implants actually helps sell the case, really. Patients look at it and they're like, I went to 2 other consults and the doctors didn't even explain it to me. Here, you're showing me exactly where you're going to be placing them, how many implants you're placing, and everything. And my
Yep.
my office is not that high tech, so but I come across very high tech
Good.
just for that
Nothing wrong with
reason.
that.
Yeah.
What's the average time of healing of the implants and the bone graft before you can start thinking about placing permanent restorations?
Usually I'm waiting 4 to 5 months before I'm going to the final restorations. I found depending on some of the implants that I'm using, whether they're coated or not, like the add-in's got the OsseoFix surface, which is like an osteoconductive surface. Sometimes you can go in 3 months.
Okay. What about TMJ considerations? It looked like in some of the cases, there were some decreased vertical dimensions and condylar malpositions in the CT. So does that come into play with these cases?
Yeah, absolutely. So when we're opening the bite, we have to take a lot of things into consideration. Unfortunately, we don't have enough time to go into occlusion and TMJ and all that stuff. But these are some of the things that we go over in the course. Because, yeah, if you're going to be opening up somebody's bite, you better feel comfortable about that, whether it's on teeth or implants.
Okay. Question about this is actually for me. If the lecture is being recorded, the answer is yes. I send the recording out to Golden Dent, and I think they typically put it on YouTube, or there's other ways that they'll let you know where it's going to be hosted. But usually that's within 24 to 48 hours. This is actually a great question. What is your preferred implant system if you were just starting the implant cases as a general dentist, not necessarily wanting to, go all in with all these variables, attachments, and all this other stuff? Is there a good basic beginner type system that you would recommend for people?
Yeah, I would recommend an implant system that is cost effective, that has support, that has multiple references. If you were to ask, are there doctors in my area using it, that also have education. We've seen a lot of implant companies out there. We've seen the very large ones that are uh, out there. I would say something in between for someone who's starting out, but I think the key criteria is someone who's going to give you support, somebody who's going to give you education, and something that is cost effective. That's not the highest price in the market, but is not the lowest either. And I found that those are the implant companies that I found work very well.
Okay. What about what's your hygiene maintenance recommendations for minimizing any future issues with the prostheses?
So most of these patients that are coming to me had some type of periodontal problem of some sort, in addition to decay and maybe some negligence. So we make sure when we get them, when we place the final restorations in, we have them sign on a thing that says we recommend a 4 to 6 month hygiene protocol. Our hygienists are all trained in how to clean these restorations. We definitely recommend a water pick. And we sort of explain to them it's sort of like a car. You invest in a car, you still have to maintain it. You still have to change the oil, change the tires, maintain the brakes. And so the same goes with these fixed restorations. And so some of these patients have traveled from far away to have this treatment done. So we recommend that they return to their general dentist. Or some of them say they want us to be their future dental provider, and so they're welcome to our practice.
Okay. For the occlusion, is it typically group function that you're aiming for?
We're looking at some type of a balanced occlusion. We want some protection as well. So I wouldn't necessarily call it a group function, but we'll talk about
Okay.
that at the course.
What are your thoughts about bridges for implant restorations? One of the attendees was saying they did 6 implants on the maxilla, 6 implants on the mandible, and restored them with 4 6-unit bridges. Any particular thoughts on that
So
design?
in the lower arch, usually if you have implants that are going quite a bit distal to the mental foramina, then you want to split the restoration up if possible, especially if it's someone who doesn't have like a thick jaw. In the upper arch, I would say 9 out of 10 times, I'm always splinting the whole restoration. So very rarely am I breaking the bridge up into 2 or 3 pieces, like may be suggested in the lower. In the upper arch, again, I've been trained by Dr. Mish, and he always recommended cross arch stabilization in the maxillary arch,
Mm-hmm.
and I would agree. It hasn't done anything wrong for me yet, so it's
Okay.
been working for many years.
Question either for you or for Kurt. Does Amplify have any virtual CE learning from home on how to do the prosthetic steps in these full arch cases?
Not yet. If the COVID continues, we may have to, but at the moment, no.
Okay. Yeah, that's what I figured. We are running up to the bottom of the hour, and we're running out of questions. So, anything you'd like to say before we call it a night?
I just like to invite people to look at Amplify Dental's website for the course that we're holding on October 9th and 10th. We'll be making sure that everybody has an opportunity to use surgical guides, level bone using these guides, and then placing the implants and some type of fixed restoration. This is what people have been asking me for over the years. And so we've been able to partner with Golden Dent, Kedenbach, Addon Implants, Carestream Dental, and 3DDX to really provide turnkey A to Z learning experience when doing these cases. And even if you're not planning on doing the surgical portion in your practice, a lot of dentists that I've trained over the years have said this type of education has been really helpful for them to open the communication with their oral surgeon or periodontist so that they can guide them in where they want the implants placed. And the general dentist now knows how to restore these cases. Is it going to be a screw retain restoration? Is it going to be a cement retain restoration? Because the implants are placed totally differently depending on the restoration. If it's a screw restoration, then the implants are placed slightly more palatally. If they're a cement type restoration, like you saw in the very first case, then the implants are placed so that they exit the incisal edge. So they're placed more directly into the socket as compared to lingual to the socket. So there's a lot of things that we go over that general dentists and even some specialists could really view as a great value and learning experience.
Well, we thank you for sharing that experience with us. One of the things I mentioned earlier in the presentation is that it's always a thrill to work with Golden Dental, and they bring in Dr. Nazarian and Dr. Kosinski on a regular basis. Every time we're seeing new cases, that great content. It's just stuff you're not going to see elsewhere, and you're not going to see the same stuff over and over again. So we thank Dr. Nazarian for his time. I know how valuable that is. Thank you again to Golden Dental for their ongoing sponsorship. You see the special there. That's, I think, one of the highest I've ever seen. Typically, they'll provide some type of 5 to 10% discount, and we got 12% here. I would certainly feel free to contact them and take advantage of that special. They stand by their products 100%. We've got dozens and dozens of our clients who are Golden Dental clients as well, and they rave about the products, rave about the service, and I would highly recommend you take advantage of that. We do these webinars on a regular basis, usually every 4 to 8 weeks, give or take. So any of you that were on tonight's webinar will be sent invitations for the upcoming webinars as well. As I mentioned already a couple of times, the session is recorded. You will get a copy of that recording within the next few days. The CE forms will go out automatically for everyone that stayed for the bulk of the presentation. That typically can take up to a couple of weeks because as I said, we had 900 plus people registered. So please be patient, but it will go out. Thank all of you for your time and your attention. We know your time is valuable as well. And we look forward to seeing everyone on our next webinar. Good night, everyone.
Good night. Thank you.